Got a special treat for you tonight. I'm gonna call my friend Ali up here to sing to you ladies. Ali! Let's go, man.
Hi guys, in today's video, I'm going to be covering drugs and common interactions. I'm going to be covering 10 drugs and some common interactions that we need to know as pre-registration pharmacists, as pharmacists, and even doctors and nurses. In today's session, I'm going to look at a number of drugs. I'm going to talk to you about some important information you need to know about those drugs. But most importantly, we'll be looking at the drug interactions that some of these drugs are involved or could be involved in. The first one is digoxin. Digoxin is a narrow therapeutic index drug. Digoxin can cause toxicity, which is why we have to monitor the plasma concentration of digoxin, because the dose or the plasma concentration at which it can cause toxicity is very close to the plasma concentration at which is therapeutic. For that reason, we have to keep a close eye on patients taking digoxin. Electrolyte imbalances can cause digoxin toxicity. And there are 4 electrolyte imbalances you need to know of. 4 electrolyte imbalances that can lead to digoxin toxicity. They are hypercalcemia, which is high levels of calcium, hypokalemia, which is low level of potassium, hypoxia, and hypomagnesemia, which is low level of magnesium. So these 4 electrolyte imbalances can lead to digoxin digitalis or digoxin toxicity. As far as the drug interactions are concerned, we have a number of drugs that can interact with digoxin. The first one is amiodarone. Amiodarone can interact with digoxin. It's a very common drug interaction you need to know. And what happens with amiodarone is we can actually make adjustments to the dose of digoxin. So when amiodarone and digoxin are being taken together, we can adjust the dose of digoxin, and we do that by reducing. We reduce the dose of digoxin by 50%. Reduce the dose of digoxin by 50%. That is important information we need to remember. The next one is quinine. Quinine can also interact with digoxin. Quinine can also interact with digoxin, and in that case, we need to reduce the dose of digoxin as well to 50%. Reduce the dose of digoxin to 50% if it interacts with either of these 3 drugs. So that's quinine, amiodarone, or dronedarone. Quinine, amiodarone, and dronedarone reduce the dose of digoxin to 50%. Digoxin can also interact with diuretics, and the way that interaction works is because diuretics can cause hypokalemia, for example, it can then lead to digoxin toxicity. So that is the nature of that particular drug interaction. We also have St. John's wort, which is a potent enzyme inducer. St. John's wort is known to interact with digoxin. So these drugs are common drugs that digoxin can easily interact with, and these are the ones that we definitely need to know about. On our list, number 2 is monoamine oxidase inhibitors. Monoamine oxidase inhibitors are a group of drugs that we can use to treat Parkinson's disease, and we can also use it to treat depression. Obviously, it's no longer first line. First line for depression is SSRIs, but monoamine oxidase inhibitors can be used to treat Parkinson's, like selegiline, for example, and rasagiline. Those drugs are still being used to treat Parkinson's And in a small number of cases, we can still use them to treat depression as well. What we need to remember is the cheese effect. Remember, at university, you were taught about the cheese effect. The cheese effect is also known as hypertensive crisis, because if a patient has any food substance at the same time as a monoamine oxidase inhibitor, that can literally increase their blood pressure tremendously. So that cheese effect is known as hypertensive crisis, because the interaction between monoamine oxidase inhibitors and certain food substances containing high levels of tyramine can increase a patient's blood pressure tremendously. So it's very dangerous. What examples of food substances are we talking about? We're talking about food substances like Marmite. We're talking about mature cheese, soya beans, red wine, game, stale food, things like that. Basically, all the things I like. All these things can interact with monoamine oxidase inhibitors and cause hypertensive crisis. The next one is sympathomimetics. Sympathomimetics can also interact with monoamine oxidase inhibitors, and they would also cause hypertensive crisis. So we're talking about some of the ingredients in cold and flu medication. So things like pseudoephedrine. So if you went to a pharmacy and you bought a box of Sudafed, for example, or Actifed, those things tend to contain sympathomimetics. Sympathomimetics like pseudoephedrine, ephedrine, phenylephrine, these things can interact with monoamine oxidase inhibitors. So they have to be avoided. They definitely have to be avoided. Absolutely important for you to avoid them. The next one is somatriptan. Somatriptan is a drug that we can use to treat migraines. Somatriptan also interacts with monoamine oxidase inhibitors. So we need to avoid that interaction by not giving a patient somatriptan and monoamine oxidase inhibitors concomitantly. We also need to know about the washout period. Washout period is in chapter 4 of your BNF. You need to be aware of the time between stopping one medication, say a monoamine oxidase inhibitor, for example, and starting a new medication like an SSRI. A very common example is the time you need to wait before starting a drug like fluoxetine after a patient has stopped taking monoamine oxidase inhibitors. That sort of thing is in chapter 4 of our BNF. So those are common drug interactions you need to be aware of. We need to be aware of those drug interactions both in our everyday practice, but also in the GPSC exam as well. The next one is methotrexate. Yes, methotrexate is a high-risk drug. Methotrexate is used for a number of indications. It's used to treat rheumatoid arthritis. It's used to treat some cancers. So when a patient is taking methotrexate, they need to be aware of quite a few things. One of those things is that it can cause blood disorder. By blood disorder, we mean side effects like bleeding, unexplained bruising, sore throat, fever, purpura, ulcers, mouth ulcers, for example. Those are common blood disorder symptoms that patients who are taking methotrexate need to be told about. They will need to be told those symptoms, so that's when those side effects, that when they notice them, they can report them immediately to a healthcare professional. We also have photosensitivity. Methotrexate is photosensitive, yes. So all patients on methotrexate need to avoid direct sunlight. They need to avoid tanning beds. They need to avoid sun lamps, things like that, because it can cause a photosensitive reaction. Methotrexate can also cause respiratory effects. So it can cause shortness of breath, for example, to patients who are taking the drug. When it comes to drug interactions, we have a number of drug interactions that we need to be aware of. A very important one is the drug interaction between methotrexate and trimethoprim. Methotrexate is an antifolate drug. It works by preventing folic acid, which is important in the manufacturing or the making up of DNA. So if there is no folic acid, it means the DNA is not going to be formed properly. The same thing happens with trimethoprim. It's also antifolate. So we can't give two antifolate drugs at the same time. We cannot give, it needs to be avoided by all means. You cannot give two antifolate drugs at the same time. So avoid giving trimethoprim and methotrexate to a patient. That's absolutely important. The next one on our list is NSAIDs. So NSAIDs are things like naproxen, ibuprofen, nefopam, diclofenac. Those drugs can also interact with methotrexate. They work by reducing kidney function. And by doing that, methotrexate could sit around in the system for a lot longer than it should, which can then increase the risk of side effects like blood disorder symptoms. So what we can do in some cases where a patient has to take methotrexate and NSAIDs is we can adjust the dose of the NSAID. By adjusting the dose, we can then reduce the effect of NSAIDs on kidney function. The next one is penicillins, like your phenoxymethyl penicillin, amoxicillin. Those drugs can interact with methotrexate as well. They should be avoided. We have aspirin. A patient shouldn't be sold aspirin over the counter if they're on methotrexate. That type of patient needs to be referred. If they say they want aspirin and they have a good reason, they need to be referred to a prescriber so that they can be assessed properly. Methotrexate can also interact with PPIs like omeprazole. Omeprazole would interact with methotrexate, so we can go for alternatives. Alternatives would be things like lansoprazole, for example. That would be a better option than omeprazole. So these drugs typically interact with methotrexate, and there's some of the common ones that we need to be aware of. As I say, the list is not exhaustive, but these are important ones that we need to know. The next one is statins. Statins are a very common drug. Statins may cause muscle effects and rhabdomyolysis, which is the breakdown of muscles. There are 5 monitoring points before the initiation of statins that we need to know. 5 monitoring points before we decide to put a patient on statins. What are those 5 monitoring points? From my head, the first monitoring point is creatine kinase. We need to check the level of creatine kinase, because if the patient has high levels of creatine kinase, it means they could potentially be suffering from some sort of muscle effect or the other. Number 2, we need to do a full lipid profile. We need to check their cholesterol levels, check their LDL, check their HDL, triglycerides, total cholesterol, things like that. We need to do a full, at least one full lipid profile. We also need to check their thyroid function. So check their thyroid function, especially for hypothyroidism. If the patient is suffering from hypothyroidism, then we need to correct that before we can initiate the drug. So check for hypothyroidism. The next one is liver function test. Liver function test. So check liver function to make sure liver function is adequate before the patient can be put on statins. And then lastly, we need to check for patients who are diabetic or could be diabetic or pre-diabetic. We need to check for diabetes. And if a patient is diabetic, we need to manage that before we put them on statins. So those are the 5 monitoring requirements, 5 monitoring requirements that you need to know. Creatine kinase, thyroid function, liver function tests, diabetes, and full lipid profile. As far as drug interactions are concerned, there's quite a few drug interactions we need to know. The very common one is macrolides. Macrolides can interact with statins, so drugs like erythromycin, clarithromycin should not be given with statins at the same time. We shouldn't give them with statins at the same time because they can increase the risk of muscle effects. It's important to tell patients that muscle effects and rhabdomyolysis, and actually they're not very common. They're not very common, but they are popular things that they can read in papers, read in magazines, but they don't happen easily. However, because of how important they are, it's absolutely important and crucial that we keep an eye on patients and tell them how to notice and report signs of rhabdomyolysis. So yes, so with macrolides, stop statins whilst the patient is on macrolides. If a patient was going to take a course of erythromycin for a week, for example, they need to stop statins whilst they're taking erythromycin and then go back to statins 24 hours after the last dose of erythromycin. Another one is grapefruit juice. Grapefruit juice needs to be avoided. if a patient is taking statins. Another one is fusidic acid, oral fusidic acid. So this is not the topical version, not the cream. This is oral topical, oral fusidic acid. Oral fusidic acid is very potent. So a patient needs to stop statins whilst taking fusidic acid. And when they finish the course of fusidic acid, they need to wait for 7 days. They need to wait for 7 days before they can go back to their statins. So they need to wait for 7 days. That is important because the drug fusidic acid is very potent. Colchicine can also interact with statins. They should be avoided, shouldn't really be taken together because of possible risk of rhabdomyolysis. If a patient is taking amlodipine, which is commonly prescribed to patients to manage hypertension, then the maximum dose of simvastatin is 20 milligrams. So if the patient is going to be on simvastatin, they shouldn't really take more than 20 milligrams of simvastatin. They can be changed to a different type of statin, like atorvastatin, for example, where they can, take 20 or 40 or 80 milligrams of atova. But as far as simvastatin is concerned, they should stick to a maximum of 20 milligrams of simvastatin. Again, because of the risk of muscle effects. Next one is warfarin. Warfarin is a common anticoagulant that is taken by a number of patients. Obviously, now we have new anticoagulants called the novel or direct oral anticoagulants like your rivaroxaban, edoxaban, apixaban, drugs like that, which are beginning to take the place of warfarin. They're beginning to dominate the management of patients who need anticoagulant medication. That notwithstanding, we still need to know our warfarin in a lot of detail. Warfarin inhibits the function of vitamin K, and we need to know INR targets for different conditions. For example, if a patient has a myocardial infarction, their INR target is 2.5. That is important. And also know that any INR result within 0.5 of the target is required, is regarded as satisfactory, right? So if a patient is within 0.5 of the INR target, we'll regard that as satisfactory. For example, if a patient who has myocardial infarction has an INR of 2.1, for example, or 2.7 or 2.8, we can still take that as satisfactory because they're within 0.5 of their target, simply because it's very difficult to get every single patient to hit the exact target. Drug interactions, we have loads, so many drug interactions that you need to be aware of. A very important one is the drug interaction between warfarin and azoles. Warfarin and azoles is a common interaction that we need to know as pharmacists, especially because some patients on warfarin will come to your pharmacy and try to buy fluconazole, for example, to treat thrush, or they can come in to buy clotrimazole or miconazole to treat other fungal topical infections. So in both cases, whether it's oral or topical, we need to avoid selling those drugs to patients who are taking warfarin, even the topical ones, because topical application can cause systemic drug interactions as well. Warfarin can interact with cranberry juice and pomegranate. Cranberry juice should be avoided by patients who are on warfarin. Also, patients who are on warfarin should have green leafy vegetables in moderation. They should have green leafy vegetables in moderation. And the reason is because green leafy vegetables contain high levels of vitamin K. So for that reason, they shouldn't stop their green leafy vegetables completely, but it's important that they have it in moderation. Warfarin can also interact with NSAIDs because taking both of them would increase the risk of bleeding to our patients. Drug interaction with amiodarone is also possible. So warfarin and amiodarone can also interact. So these ones are common drug interactions that we need to know for warfarin. There's loads of other ones, but these ones, I believe, are very common ones we all need to know. Question number 6, I have theophyline. Theophyline is another narrow therapeutic index drug. Theophyline is normally given to patients who have chronic asthma, for example, and the target serum concentration is 10 to 20 milligrams per liter. 10 to 20 milligrams per liter is the target serum concentration for theophyline, and it needs to be within this range for most people, otherwise it can lead to toxicity. If a patient takes theophyline in excess and it causes toxicity, we can manage their toxicity by giving them activated charcoal. So give activated charcoal to patients who have taken an overdose of theophyline, because the antidote is activated charcoal. We also need to know about the drug interaction between theophyline and tobacco in cigarettes. When a patient is smoking cigarettes, we need to increase the dose of theophyline. Why? Because tobacco is a potent enzyme inducer. Tobacco is a potent enzyme inducer. So what it will do, it will reduce the amount of theophyline in the system, the bloodstream. So we need to increase the dose of theophyline whilst the patient is smoking. And when they stop smoking, we need to reduce the dose back down again. Does that make sense? So increase the dose if a patient is smoking, and when the patient stops smoking, reduce the dose of theophyline. Diuretics can also cause drug interactions with theophyline, because some diuretics, of course, can cause hypokalemia. They can cause loss of kalemia. And guess what? Theophyline can also cause loss of potassium. Theophyline can also cause loss of potassium. There's a drug interaction between phenytoin and theophyline, yes. Another important drug interaction between theophyline and erythromycin, which is a macrolide that we use to treat quite a number of infections. So these ones are important drug interactions that we need to know about. Extremely important, these ones are. Moving on to number 7, I have omeprazole. Omeprazole is a very common proton pump inhibitor. Omeprazole is the only proton pump inhibitor that can be taken in pregnancy. So we have about 5 different PPIs that are widely prescribed and dispensed in the UK. And out of those 5 PPIs, we have omeprazole as the only one that we can obviously prescribe in pregnancy. PPIs have 5 major long-term effects. Obviously, it doesn't happen to everybody, but it's important to be aware of some of the long-term effects of taking PPI. What are those? The first one you need to be aware of is that PPIs can mask gastric cancer symptoms. They can mask gastric cancer symptoms. That is the first one you need to know. The second one is they can also increase the risk of lupus. They can increase the risk of lupus. By increasing the risk of lupus, the patients could end up with skin disfiguration. Sometimes it affects the face of the patients, etc., etc. It's actually a very nasty condition, lupus. The third one is that PPIs can cause gastric infections, like C. diff infections, for example. Remember that the guidelines have changed recently, and the first line management or treatment for C. diff infections is now vancomycin. Vancomycin is our first line drug to treat C. diff, and our second line is fosfomycin. So those are the drugs to treat C. diff infections, which can be brought about by taking PPIs. PPIs can also cause hypomagnesemia, so they can cause loss of magnesium. Loss of magnesium is one of the things we need to remember as far as the long-term effects of PPIs are, and patients have to be advised to monitor their levels of magnesium by doing a blood test from time to time. Lastly, PPIs can cause osteoporosis. PPIs can cause osteoporosis, which is a condition where the bones of our patients become very brittle and can easily break or fracture. As far as drug interactions, we have interactions with 5 common drugs: warfarin, methotrexate, escitalopram, clopidogrel, and citalopram. So we actually have a mnemonic for this one. The mnemonic is omeprazole interacts with MESI. I've written it out. So omeprazole interacts with MESI is our interaction mnemonic for these drugs. So with MESI, that with basically is warfarin. That with stands for warfarin. And then M stands for methotrexate. E stands for escitalopram. The first C stands for clopidogrel. And the CI stands for citalopram. So these drugs are drugs that commonly interact with omeprazole. Let's take one of them. Let's take clopidogrel. If omeprazole interacts with clopidogrel, what do you think will happen? What would happen if a patient took omeprazole and clopidogrel? The problem with taking omeprazole and clopidogrel is that omeprazole will reduce the antiplatelet effect of clopidogrel. By reducing the antiplatelet effect of clopidogrel, it can then predispose the patient to things like strokes, blood clots, and other cardiovascular events. So if you see a drug like omeprazole being taken with clopidogrel, you need to contact the prescriber and let them know that that omeprazole needs to be changed to something safer like lansoprazole to reduce the risk of cardiovascular events. The next one, number 8, is Viagra Connect. Viagra Connect can now be bought over the counter by men who are aged 18 years and over, who also meet the criteria. So there's a number of criteria that they have to meet, and we need to know those criteria, or at least have the form ready for them to fill out. It's a questionnaire they have to fill out before we can supply Viagra Connect over the counter as pharmacists to make sure that the medication is suitable for that particular patient to take. As part of the criteria, we need to check for drug interactions, which is also on the questionnaire. And those drug interactions include if the patient is taking an alpha blocker. So alpha blocker are drugs like tamsulosin, alfuzosin, prazosin, those type of drugs, sulfenacin, they can interact with Viagra Connect because Viagra Connect can cause hypertension, hypotension, and alpha blockers can also cause hypotension. So taking 2 drugs that can cause hypotension can increase the risk of falls, for example. Yeah, so we should avoid selling Viagra Connect to patients who are taking alpha blockers. Avoid it if the patient is taking erythromycin as well, which is a macrolide. Avoid Viagra Connect if the patient is taking erythromycin. Refer them to a doctor instead. Nitrates will do the same thing. Nitrates can also lower blood pressure. So avoid selling Viagra Connect to a patient who is taking nitrates. If the patient has had a stroke within the past 6 months, if a patient has had a stroke within the last 6 months, that patient needs to be referred. Refer all patients who have had a stroke within the last 6 months to a prescriber for further discussion and investigation before they can be given the drug. Number 9, I have amiodarone. Amiodarone is a high-risk drug. It's also a narrow therapeutic index drug. It has a long half-life. It does. And with amiodarone, if a patient stops taking amiodarone, they need to carry on behaving like somebody who is still taking amiodarone for many months, even after they've stopped. Why? Because the drug stays in the system for months, even after stopping the medication. So things like avoiding direct sunlight or UV light or tanning beds or things like that, they need to carry on avoiding those even after they've stopped taking the medication. They need to avoid grapefruit juice. Grapefruit juice would interact with amiodarone as well, so that needs to be avoided. If a patient is going to take digoxin and amiodarone, like I said before, we need to reduce the dose of digoxin to 50%. So reduce the dose by half of digoxin to reduce the risk of serious drug interactions. Amiodarone can also increase the risk of bleeding with warfarin, and it would definitely, or it can definitely interact with phenytoin. phenytoin. So these things are important things we need to know about amiodarone. Lastly, may I add that amiodarone can cause corneal microdeposits. Corneal microdeposits in some cases can lead to blindness. So if a patient comes to you and complains that they have symptoms of corneal microdeposits, which is affecting their vision, so they have pain in their eyes, for example, or discharge coming out of their eyes, or they have some sort of visual impairment, that patient needs to be referred urgently to A and E. So refer that sort of patient to A and E. Lastly, I have St. John's wort. I have St. John's wort on the list. St. John's wort is a common herbal medicine which is taken by some patients, especially older and elderly patients, to manage depression. Some people believe it works in the management of depression, but because in the UK we practice evidence-based medicine, we're not allowed to recommend St. John's wort to a patient. For that reason, we have no evidence that it definitely works. Also, it's a potent enzyme inducer. So it has loads of drug interactions with other medication that the patient may or may not be taking. So it's important for us not to recommend drugs without evidence. The drug interactions that we need to know are aminophylline. St. John's wort would interact with aminophylline. It can interact with phenytoin. It can interact with contraceptives. So both COCs, combined oral contraceptives, and progesterone contraceptives like desogestrel, for example, those drugs can be affected by St. John's wort because St. John's wort will reduce the plasma concentration of contraceptives, which predispose the patient to getting pregnant. It can interact with vinca alkaloids. It can also interact with warfarin, theophyline, and statins. All right, so all those drugs are drugs that can potentially interact with St. John's wort, and there's loads more as well. So only recommend for patients to take drugs that have evidence to back it. We have an upcoming set of mock exams, guys, for pre-registration pharmacists who are watching, the ones that are preparing to sit the exams on the 3rd of November. We do have some mock exams for pre-registration pharmacists coming up, which the details are on our website. So if you're interested in calculations mock exam or clinical mock exams, there's details available for you to register for those mock exams on our website. On this particular slide, I have all our details. If you wanted to get back in touch with us, you can message me on Instagram at London Pharmacist Network. You can join our Facebook group. You can send me an email. You can go on our website and have a look. You can also give us a like if you like today's session and you found the content valuable. Subscribe to the channel to help our channel grow. It's been a pleasure recording this particular video for you, and I want to wish you all the best with your exams and your careers. Wherever you're watching from, have a lovely evening.